Hi everyone! In this video we're going to describe the anatomy of the respiratory system, and in doing so I'd like us to keep in mind a couple of important functions. So the respiratory system provides an extensive surface area for gas exchange. It allows for the air to be moved to and from the exchange surfaces, which would be the lungs. It's responsible for protecting respiratory surfaces from dehydration, changes in temperature, environmental variations, and pathogens. It also is responsible for production of sound and detection of olfactory stimuli. So in this drawing, we're just going to sort of take a look at the air, all of the passageways and the structures. And we can see the air can actually flow in through the nose. The entry into the nose is the nares, and then the air inside is in the nasal cavity. It can flow backwards towards the nasopharynx. It can also enter through the mouth and then reach the oropharynx, and then deeper it gets to the laryngopharynx. The nasopharynx, oropharynx, and laryngopharynx all together make up the pharynx. Below that is the larynx, which actually contains the epiglottis, and then the air passes to the trachea. The trachea divides at the carina into the right and left primary bronchi, and we can see that in this drawing it's anatomic, so the right is actually the patient's right, and the air will actually travel through the primary bronchi until the bronchi will break down into secondary bronchi and a bunch of bronchi until we get to bronchioles, which are really, really small. And then eventually the air reaches the alveoli, which is the surface area for gas exchange. The air enters the lungs through the hilum. So it actually, once the structures actually become part of the lung, we call it the hilum. And of course in this picture we can identify the diaphragm as well as the heart. And so this is really a gross overview. We're going to actually kind of zoom in and take a look at each of these structures. But for now, I just want to have some perspective of where everything is relative to the other structures. And also, one thing that we think about a lot about is separation of the upper airway and the lower airway. And especially if we're thinking about upper airway obstruction versus lower airway obstruction. So it might be useful to think of that as the larynx is the structure that actually separates the airways. So most of the respiratory system has, most of the lining of the respiratory system is respiratory mucosa. So mucosa means a mucous membrane, basically a epithelial layer of tissue and a connective layer of tissue, and then also some cells that secrete mucus. So in the majority of the respiratory tract, we have the lining is made of pseudostratified ciliated columnar epithelium, meaning that the cells are columnar and they look stratified, but they're really simple. There are also some goblet cells, and those guys are kind of like in between the epithelial cells, and they produce mucus, and that actually is on the surface, the apical surface of the epithelial cell. We also notice that the apical surface is where the cilia is located because the cilia actually sweep that mucus. Of course, we can't have epithelium without a basement membrane. So the basement membrane is the basal surface of the epithelium sits on the basement membrane. And then deeper to that, we have some connective tissue. The connective tissue that's specific to the respiratory mucosa is called lamina propria. And it's actually highly vascular, so there are lots of blood vessels in the lamina propria. And then also, and as we work our way down the respiratory tract, this changes a bit, but there is an abundance of smooth muscle cells, increasing in number as we work our way down. All right, so I know it's kind of a lot for an overview, but we're gonna sort of review and sort of focus on each piece as we work our way through the respiratory anatomy. So first we'll start with the nose, the nasal cavity, and the mouth. And we notice the respiratory mucosa is present here. So let's just kind of label the drawing. We have our nasopharynx, we have our oropharynx with different tissue structures. We have our nasal cavity, so it's kind of like a sagittal section. And the nasal cavity and the nasopharynx are both lined by respiratory mucosa. So if we think about the air entering, once again, the air can enter through the nares, so there'll be one nare on each side of the nose, and the nasal cavity is divided by the nasal septum, and then the air can pass through either nare or either nostril. Now on the lateral aspects of the walls, we have the nasal conchae, and those guys are actually, they're kind of like scroll shaped or scroll-like projections from the lateral wall. And so they're on either side, and their job actually is to increase the turbulence of the air as it enters. So it kind of makes the air tumble as it enters into the nasal cavity. And what that does is it causes some of the heavier particles in the air to actually stick to the mucus on the wall, so it doesn't actually pass into the lungs. Of course, the air can also enter through the mouth, and we notice that the mouth and the oral cavity is separated from the nasal cavity by the hard palate, which is made of the maxillary and palatine bones, and then also the soft palate, which is basically more posterior than the hard palate, and it's basically just made of muscle. So let's talk for a moment about the oropharynx, and then of course we can sort of add into our drawing here the laryngopharynx. So we know that nasopharynx, oropharynx, and laryngopharynx makes up the pharynx, but the tissue structures that line the oro and laryngopharynx are actually stratified squamous epithelium, so it's different than what we have in the nasopharynx and the nasal cavity. And this is actually because food and liquids that are passing through can be kind of like harsh on the tissue, so having this stratified epithelium is better in terms of maintaining that surface. Alright, as we work our way down, we can see that the air is going to pass next sort of through the larynx and then also down into the trachea. It could also go to the esophagus, but that's obviously not our purpose. So we draw the tongue in to sort of just keep in mind the size of the tongue, the location of the tongue, the fact that the tongue takes up a lot of space when the mouth is closed. And then we can just label the structures that make up the larynx. So we can see the thyroid cartilage and the cricoid cartilage, so two sort of like not full rings, but sort of partial rings of cartilage, and they are separated by the cricothyroid membrane. And this is important because the cricothyroid membrane is actually what's punctured when doing a surgical cricothyrotomy. So if a patient needs a trach tube instead of an endotracheal tube, that's the kind of point of puncture. We can see the epiglottis. The epiglottis function is to basically cover the glottic opening. So epiglottis meaning above the glottis, and then the glottic opening is basically where the vocal cords are. So this is important because the vocal cords are, first of all, when the air rushes past them, they vibrate to produce sound, but it's also the point of entry into the trachea. And so anything that's going to pass through is going to the lungs, and we want to make sure that the only thing that passes through is air, so it's safe for the lungs. And so whenever swallowing is happening, especially if we're talking about swallowing food or liquid, it's kind of difficult to tell from the drawing, but the structures actually move up so that the epiglottis covers the glottic opening and prevents anything from passing through the glottic opening into the trachea that doesn't belong there. And we'll kind of talk about what happens if that occurs in a moment. We'll also notice as we move down back into the trachea, we see that the respiratory mucosa returns. Alright, so in this next drawing we can see, this is actually a transverse cut, and we can see the epiglottis, we can see retinoids, which is basically the other sort of border for the structure, and then we see our vocal cords right in the middle there. So the proper name for the vocal cords is vocal folds or true vocal cords. And on either side of the vocal cords, we actually have vestibular folds. And so really when we think about endotracheal intubation, this is kind of our view. We're lifting up the tongue, we're visualizing the epiglottis, and depending on what blade we're using, it determines what method, what we'll do with the epiglottis, whether we'll pick it up or whether we'll kind of press above it. But either way, this is a beautiful view of the vocal cords that we're looking for. And so these guys, the vocal cords are going to open and close in response to air movement, and also sort of as far as like protection is concerned. So one thing I really want to mention for a moment is the cough reflex. So generally we think of gag reflex. We think of, oh, the patient accepted an OPA or didn't accept an OPA or something like that. And I just want to point out that absence of a gag reflex does not mean absence of a cough reflex. So a cough reflex, basically if any food or liquid touches either the vestibular folds or the vocal folds, so it's not even just those vocal cords, it's kind of anything that it kind of makes up that tissue layer, the glottis immediately closes, and I guess we could more appropriately say it slams shut, and then the chest and abdominal muscles will contract, which will build pressure inside of the chest cavity, particularly in the lungs. And when that pressure rises beyond what the glottic opening is capable of sort of withstanding, then the compression of the lungs will actually cause the glottis to be forced open, and we get this eruption of air and any materials that might have kind of either hit that surface or maybe even gotten past that surface. All right, so now let's take a look at the trachea. So the trachea is closely associated, anterior to, but closely associated with the esophagus. And we'll just kind of draw the structures in here. So the trachea is enclosed by some cartilage rings, and the cartilage rings are not all the way around. They're sort of like a C shape. So we can see that kind of protecting the trachea. So we see our trachea, and then we see our esophagus in green, and the separation between the two of them, since that cartilage ring is not all the way around, is the trachealis muscle. So the trachealis muscle has the ability to contract and relax, and as it plumps up, it actually takes up more space in the trachea, whereas it flattens out or relaxes, it will take up less space in the trachea. It's under sympathetic control, so with sympathetic activation, we can actually relax the muscle and increase the diameter of the trachea. We can see the cartilage ring, and then inside we have respiratory mucosa, so the same structure that we had before with our epithelial cells and our goblet cells and the production of mucus. And then we also have another layer called submucosa that's sort of deeper than the mucosa, and it contains submucosal glands. And I mention that because airway secretions can come from both the mucus from the goblet cells and also from the submucosal glands. All right, so the trachea branches into the right and left primary bronchi, and when we mentioned that split is at the carina. And so a couple things to note about the right versus the left primary bronchi. The right is actually larger in diameter than the left, and it also descends at a deeper angle. So one thing we talk about a lot is intubation and a right main stem intubation. I just want to sort of show from this picture that pushing a tube down a little bit further than it's supposed to go, it's pretty easy for that to end up being a right main stem tube because it's just sort of like the natural pathway of where we're going. A little bit more difficult to left main stem. So we mentioned before that the entrance to the lungs is called the hilum, and basically before the primary bronchi branch any further, they actually enter the lungs. So now we'll just draw a lung, and I just want to point out that first the top of the lung is called the apex, the bottom of the lung is called the base, and the lung is actually divided into sections called lobes. And so on the right side there are 3 lobes, and on the left side there are 2 lobes. The left side there's only 2 because the heart is taking up some of the space. And so the secondary bronchi, so the primary bronchi branch to secondary bronchi, and so there will be 3 secondary bronchi on the right side and 2 secondary bronchi on the left side, so 1 for each lobe basically. And then the secondary bronchi can branch further into tertiary bronchi and quaternary and so on, so they get smaller and smaller and smaller, and they branch a lot, and then eventually they branch to bronchioles, and they're called bronchioles when their diameter is less than 1 millimeter. One other thing I want to mention is that cartilage sort of surrounds, just like the trachea, cartilage surrounds the bronchi and the bronchioles, but as we work our way down from bronchi to bronchioles, we decrease the amount of cartilage and we subsequently increase the amount of smooth muscle cells that surround the bronchi. And so that actually allows for an increase in control of the diameter of the bronchioles. So the autonomic nervous system is responsible for regulation of the diameter, and we'll just sort of review quickly. So we have our sympathetic neurons here. Preganglionic fiber releases acetylcholine, which binds to a nicotinic acetylcholine receptor, and then we get a new action potential and then release of norepinephrine. And norepinephrine binds to a beta-2 receptor, which is a G protein coupled receptor on a bronchial smooth muscle cell. And from there we get a cascade of reactions, so we're going to fast forward a little bit, that ultimately result in, so we generate cyclic AMP as our second messenger, and then what we get is a decrease in calcium inside the smooth muscle cell, which leads to smooth muscle cell relaxation, and therefore bronchodilation. So sympathetic activation ultimately leads to smooth muscle cell relaxation, and bronchodilation in the bronchial cells. And then we could compare that to the parasympathetic innervation. So parasympathetic control, we have same sort of thing. From the preganglionic fiber to the post, we release acetylcholine, which binds to a nicotinic acetylcholine receptor. And then we have a new action potential. And then when the postganglionic fiber synapses to this bronchial smooth muscle cell, we use acetylcholine again, and it binds to a muscarinic acetylcholine receptor, and that muscarinic acetylcholine receptor is also a G protein coupled receptor, and so binding will also generate a cascade of reactions that leads to second messenger formation, and the second messenger formation will in this case lead to increased calcium, smooth muscle cell contraction, and bronchoconstriction. So parasympathetic activation, not so good for diameter of the bronchioles, but bronchodilation improves the diameter, makes the airflow a little bit better, a little less resistance to airflow by increasing the diameter of the airway. So one thing I just want to mention is that although in the upper portions of the bronchi, we maybe don't have smooth muscle cells wrapping entirely around the tubes, as we get down to the bronchioles, you can actually see that we have a whole bunch of smooth muscle cells all the way around. And these smooth muscle cells, this is more of a refresher, but if we have the smooth muscle cell flattening out, that will be relaxation. If we have it plumping up, that would be contraction. And so flattening means that we're going to increase the diameter, and plumping means that it's going to take up more space. Each cell takes up more space of that lumen, and so therefore it's going to decrease the amount of space that we actually have for airflow. And of course, these things can be modified by administration of certain drugs. Alright, so almost to the end. Now we're just going to talk a little bit about alveoli. So the alveoli are basically thin-walled air sacs that are specialized for gas exchange. So when we draw the alveoli, we typically draw them to look like bunches of grapes. So I just want to mention that if we have the bunches of grapes, that's our alveolar sacs, or we could say alveoli. And then if we were to draw it singularly, so just one little grape, then we call that an alveolus. So that's alveolus is the singular form, as opposed to alveoli, which is many, or the alveolar sac, which looks like the bunch of grapes. So let's just draw it a little bit bigger and take a look at the tissue structures that we're going to see, and what's going to happen here in terms of stuff crossing this membrane for gas exchange. So we have our action that's in the alveoli, and then we have a single layer of epithelial cells, which is simple squamous epithelium, which basically lines the alveoli. So these guys are called alveolar type 1 cells, and they are, so it's just a single layer of cells that are attached to a basement membrane, and then right on the other side of that basement membrane is the capillary endothelium. So remember, the capillary endothelium is basically the epithelial cells that make up the capillary, and it's also simple squamous epithelium, and it's also so of course, being simple, it's a single layer. So essentially, when we have gas exchange, we're talking about oxygen passing across one cell for the alveoli, the basement membrane, and then one cell for the capillary endothelium. Good thing that oxygen is small and lipid soluble, because it makes it really easy for gas transport to occur. But I just want to offer a reminder, which is that the major factor that allows this to happen is the distance is very small. So if the distance goes up, it can dramatically impair the ability of good gas diffusion. So the oxygen diffuses into the capillary lumen. One other thing we want to mention about the capillary endothelial cells is they produce ACE, which is angiotensin converting enzyme. So this is basically an enzyme that produces a hormone called angiotensin 2, which regulates blood pressure and blood volume. So essentially, this enzyme is a contributor to maintaining blood pressure and blood volume. Alright, so a couple of things we want to mention about the alveoli. So we have these alveolar pores that exist between the alveoli. So the alveoli, the bunches of grapes, are kind of all connected to each other. They have these little holes in between them. And this actually functions to equalize the pressure between the alveoli. So if one alveolus blows up, it can distribute the volume of air or gas across the alveoli, so it's more of an even distribution. All right, and then lastly, let's just take a look really quick at. So here's my attempt at a three-dimensional drawing of the alveoli. So when we say squamous, we know the cell is flat, but it can look kind of squarish in this picture. And then in green, we're drawing some cuboidal epithelial cells that also appear sort of sporadically throughout. These are called alveolar type 2 cells, and their job is to produce something called surfactant. So they produce and secrete surfactant. And surfactant is basically sort of like a watery substance that lines the inside of the alveoli, so like inside the simple squamous epithelium of the alveoli. And so one thing we like to think about a lot when considering an alveolus is like it's kind of like a little balloon. When there's no air in the balloon, it's kind of hard to blow it up. If the balloon is kind of collapsed or flopped over, it could take a lot of pressure or force to get a little bit of air into it. So we want to keep it slightly inflated all the time. And one thing that is kind of complicated is that, as you can see, right around the entire alveolus, we have this capillary, which is filled with water. So we have what's called an air-water boundary, where the gas exchange is actually occurring. And there's a lot of surface tension at an air-water boundary. So really what happens is the alveoli want to sort of collapse over because hydrogen bonds want to form in the water that's sort of around it. And so the secretion of surfactant lining the inside of the alveolus actually reduces the tendency to have this collapsing over, folding over, based on the air-water boundary. So it helps the lungs, it helps the alveoli stay slightly inflated so that it's easy for a gas exchange to occur under normal physiologic circumstances. All right, so that concludes our overview of the respiratory anatomy. And then as we work our way through the different components of physiology, we can sort of refer back and relate the concepts of anatomy to the other topics. So I hope you enjoyed it. Thanks for watching.